please.
Okay. Okay.
So it's a great pleasure. Thank you, Kim, for this. And it's good to meet up, if virtually, for friends that I haven't seen for a long time, Howard and Richard in particular. So I came to Oxford in 1983, and essentially owe Peter Morris my career since that point. Did research with Catherine Wood. I thought I was her first research fellow, but I think actually I was probably just about her second. But I took a screenshot of this that Richard did because I saw myself next to Jeremy Chapman, there, a young David Cranston back in 1984. So many good friends there. So I'm going to do this slightly differently from the way I normally do it. I normally talk about the prevention first, but actually I'm going to talk about the problem and then the cure, and then we'll look at the prevention. So the problem, as of course anybody in transplantation knows, is the main problem urologically is obstruction and leaks. In the past, we thought that reflux was a major problem, and indeed, Peter, in the early days, Peter Morris was always very insistent on opening the bladder and tunneling it properly to prevent reflux, because he had one patient who died of sepsis after apparently reflux. But in fact, I think there's no evidence that certainly sterile reflux has any problems. And certainly in normal urology, reflux, certainly later on in life, doesn't seem to cause a huge number of problems, although it can cause symptoms sometimes. Stones is a problem that one sees. There are these other problems, which I won't have time to go into, looking at prostatic outflow obstruction, especially as one's transplanting the older patients. Neoplasia, interestingly, we've seen a couple of tumors in transplanted kidneys, and we haven't always taken the kidney out. We treated one successfully with a high intensity focused ultrasound, which is a big research interest of mine. And I did then do a partial nephrectomy on that patient, but 90% of the tumor had been ablated. We've also done partial nephrectomies on a couple of other patients successfully. So it's not mandatory, especially these days with the lower dose immunosuppression compared with the earlier days, to necessarily take the kidney out. So let's talk about the normal ones. This was a paper that Ed Streeter, one of our fellows, Peter Morris and I wrote up in 2002, looking at the 1,535 kidneys that had been done in Oxford. And the percentage there was about 8%, just over 8% of complications. And most of them, as of course we'll all be aware of, are leaks and obstruction. And of course, again, as one knows, in the early days of high-dose steroids, complication rate was much higher and became much lower when the lower-dose steroids were used. And although I haven't got a picture of him, I think it's worth mentioning a colleague of ours, Derek Gray, who was a great friend and did a lot of work on the low-dose steroids, who sadly died a few years ago. But I think a lot of the early research that was done in Oxford was done in association with Derek Gray. So the incidence varies in the different series, but the presentation of leaks is as shown there: pain, swelling, discharge, and urinomas. And early obstruction can be those things: twisted ureters, edema at the vesico-ureteric junction, sometimes hematomas or lymphoceles. Occasionally a suture might just obstruct it if that's been misadvertently placed, and occasionally blood clot, although that often would resolve. And the later obstruction strictures and fibrosis. Sometimes you can get pelvic-ureteric junction obstruction, or sometimes indeed you can transplant somebody who's unknown to have pelvic-ureteric junction obstruction, and then lymphoceles, calculi, carcinoma, and occasionally fungal balls. We've seen one or two of those in the years. Again, here's Hydra nephrosis with stricture, dilated ureter here, and stricture at the lower end of the ureter. Again, an antegrade study showing no dye going into the bladder down at that point. So curing them, well, before 1986, everything was done by open surgery, but since then, with the advent of increasing radiological expertise and endoscopic techniques, antegrade stents have made a lot of difference. Very difficult for any of you who've tried to put retrograde stents in. Occasionally, we were able to do it with flexible cystoscopes, but antegrade J stents is normally the easiest way to treat it initially, and sometimes the radiological treatment is enough and will sort the problem out, but sometimes still a surgery may be needed. Here's a CT scan, of course, with a stent in a transplanted kidney. And stones can be removed percutaneously. And of course, the kidney is, on the one hand, easily accessible, but on the other hand, due to, there's often quite a lot of fibrosis, and some of my colleagues who've done this said it's actually quite tough to actually get through and into the kidney, but stones can be removed that way. So sometimes surgery, open surgery, is still necessary, and it's important to remember, firstly, that there is no distal blood supply to the ureter, and secondly, of course, that the patient is on immunosuppression. So it means that you cannot cut the ureter and reanastomose it, as one can do in the ordinary patient if you've got the blood supply, which often comes up from the superior vesical artery supplying the lower part of the ureter, and down from the renal artery, and sometimes some small branches which come across from the aorta. But of course, in the transplant, you're entirely dependent on the lower pole, if there is one, or of the branches of the renal artery which supply the ureter. So you can, of course, cut the ureter and reimplant it. You can do a Bihari flap and move the bladder up to a ureter if the ureter won't stretch, or indeed just mobilize the bladder and hitch the bladder onto psoas muscle, which if you've completely mobilized the bladder, it extends it up. You can put the native ureter onto the right high up onto the transplant up near the kidney, the pelvic-ureteric junction, or even the pelvis of the kidney. And certainly we never had any problems in tying the distal end, the proximal end of the ureter in the native kidney, even if it was still producing a little bit of urine. We never had any issues with that at all. You can put it onto the native ureter, and or as I said before, just directly onto the renal pelvis. Just go back one. There we go. So surgery is often quite difficult and challenging. It's often difficult to work out exactly where the anatomy is, especially as you're tracing the ureter down, and you obviously don't want to go into the renal artery at all. And I found that it was easier to find the transplant ureter near the bladder and then trace it back up. Obviously, if there's a stent in place, that helps. If you cut blindly down by the bladder, you're less likely to do any damage than cutting blindly up where you're likely to run into the renal artery. That, of course, is the Bihari flap. and just the psoas hitch, mobilizing the bladder and hitching it up, tying off the kidney and just putting the native ureter, which of course does have a distal blood supply, so you can do that with the native ureter and put it onto the renal pelvis. But what about prevention? Well, prevention is better than cure. I had these pictures some time ago. It's much better to put a fence up at the top of a ski run than to pick up a patient down the bottom afterwards. And so donor surgery is important. As we said before, I was doing, before the endoscopic living-related donors started in Oxford, I was doing all the living-related, taking the kidneys out with Peter Morris, putting them in. We had one very close disaster when, for reasons that I won't go into in more detail at the moment, the tie came off the artery and the vein just after the kidney had been removed, and 14 units of blood, a splenectomy. Later, I crawled out of theatre and was unable to go to sleep until 2 o'clock in the morning. Fortunately, my wife had brought her the video of the mission, so we sat and watched that at midnight. The patient recovered, but it was on Peter Morris's 55th birthday, and the closest we ever came to disaster with a living-related donor. So taking it out, it's important to avoid this area, the golden triangle. Keep lots of tissue around the ureter. Think about the congenital abnormalities, and of course, a lot of kidneys with abnormalities are now being transplanted. In Oxford, in the early days, certainly when we looked at the figures, those 1,535 transplants, 90% were cadaveric, 10 living related. Now, having just spoken to Peter, who I have to say has been a wonderful friend and colleague since he arrived in Oxford, cadaverics are just under 70% and the livings are 31%. As far as the bench surgery goes, just avoid traction, care with perfusion, watch the ureter. And of course, any lower polar arteries are going to be the ones that supply the ureter. So they in particular need preserving. The upper polar ones aren't quite as important. And the recipients, keep the ureter as short as possible. Reflex doesn't matter if it's sterile anyway. Stents don't make up for bad technique. So in conclusion, they are challenging, and I found this some of the most challenging surgery because the anatomy of all of them is just slightly different, and you're never quite sure where the renal artery is, especially as you're tracing the ureter up. It's important to understand the modified principles of the ureter and the anatomy. The potential for graft salvage is excellent. Keep the periureteric tissue. This was a paper that I saw that was done a couple of years ago, where they suggested that the leash-Gregar and stenting decreases the complications. Ultrasound's important for early detection, and the prognosis is excellent if recognized and treated in a timely manner. So thank you very much. It's been a great privilege to join with you in this